Hello everyone. So today I am going to discuss about the topic primary hyperaldosteronism. So basically in this hyper means that increase and aldosterone means aldosterone level. So increase in the aldosterone level. Primary it is because there is damage in the itself of the gland, that why it is primary. If it is secondary, then maybe the cause is something else like cirrhosis or nephrotic or congestive heart failure. Due to them there is increased level of aldosterone, that's why we call it secondary hyperaldosteronism. But here the cause is itself in the gland, like maybe there is some kind of a tumor or maybe some hyperplasia is there, that's why the aldosterone level is increased, that's why we called it primary hyperaldosteronism. So the most common cause for this is bilateral adrenal hyperplasia. Almost around 90% causes were due to the bilateral adrenal hyperplasia. And the tumor, if there is the cause is the tumor, then tumor in the first layer of the cortex, as we all know that the first layer is zona glomerulosa. So if the tumor in the first layer of that adrenal cortex means the aldosterone level is increased. So if the cause is tumor, then we called it Conn syndrome, and if the cause is hyperplasia, then it is primary hyperaldosteronism. So basically what are the features, how the aldosterone level works on our kidney. So when there is increased level of the aldosterone, basically aldosterone acts on the epithelial sodium channel. As we know, the epithelial sodium channel cause the reabsorption of the sodium and water, and in contralateral to it, potassium and hydrogen loss will be there. So as the sodium and water reabsorption is there is increase the plasma volume and contralateral loss of potassium and hydrogen. So what were the clinical features? How do we identify the that the patient has hyperaldosteronism or the patient has the Conn syndrome? So the clinical features were like the patient has headache. Why there is headache? Because there is increased level of the plasma volume, which cause the hypertension. So hypertension is the cause of the headache. And muscle cramps are there. Muscle cramps is due to the hypokalemia, because there is potassium loss, which cause the muscle cramps. And metabolic alkalosis, as we know, there is loss of the hydrogen ions, so it causes the metabolic alkalosis in the blood. And the patient have polyuria and polydipsia feature. Why the polyuria and polydipsia? Because as we see that the aldosterone level increases the sodium and water reabsorption, so there is gain of water. And if the water is reabsorbed, it means that there is expansion of the volume and the venous return is also increases. So the atrial natriuretic factor releases. So as the atrial ANF release, which it causes the loss of the water. So there is balance between the reabsorption of water and loss of water. So that's why in this case, in primary hyperaldosteronism or in the Conn syndrome, there is no pedal edema. So this is the most rememberable point, that there is no pedal edema in the primary hyperaldosteronism patients. So next, what were the investigation we can do in primary hyperaldosteronism or in the Conn syndrome? So basically, as we see that in the CBC, we can check the sodium and potassium level, like increase in the sodium level, because there is reabsorption of sodium and water. So sodium level is increased and potassium level is decreased due to loss of the potassium and hydrogen ions. And in ECG, we see that there is the T wave smaller or absent. As we know that T wave depend on the potassium level. So if in this potassium level is less, so it causes the T wave smaller or absent or inverted T wave we find. And there is ST depression also can be seen. So what is the imaging of choice? So imaging of choice is CT abdomen. Why the CT abdomen is the imaging of choice? Because the primary hyperaldosteronism is caused by the adrenal hyperplasia or tumor. So we can see in the CT of the abdomen adrenal hyperplasia and tumor. That's why it is the imaging of the choice. And best screening method is plasma renin by plasma aldosterone ratio. So what happens whether it is decrease or increase? So as we know that due to the tumor of the gland, increased level of the aldosteronism, when the aldosterone level is increased, it inhibit the renin angiotensin aldosterone system. When renin is decreased, so in the ratio as renin upon aldosterone, it means that renin is decreased and aldosterone is increased. So overall there is decrease in the ratio of the plasma renin by aldosterone ratio. So this is the best screening methods. And what is the investigation of choice? As we see, the investigation of choice is salt infusion test or salt loading test. And in this primary hyperaldosteronism, there is low renin hypertension. So now we come on the treatment. So in treatment of the Conn syndrome or adrenal hyperplasia, as we know, Conn syndrome is due to the adrenal tumor. So in adrenal tumor, it means that we, in the treatment, we have to do some kind of a surgery. So basically, in the initial stage, we have to give the patient for 4 to 6 weeks spironolactones. As we all know that the spironolactone is the potassium sparing diuretics, which decrease the potassium level loss, and it manage the both hypertension and hypokalemia. And then after pre-anesthetic checkup, we do the surgery, and unilateral laparoscopic adrenalectomy can be done, as it is the definitive treatment. So it is the definitive treatment. So in Conn syndrome, spironolactone is given for 4 to 6 weeks, and it is initially given, not after the surgery or something else. And in the treatment of the bilateral adrenal hyperplasia, so the drug of choice here is the lifelong with spironolactone. And as we all know that the spironolactone has the one side effect, that is gynecomastia in males. So to prevent from the gynecomastia in males, we have to give the alternate drug of the spironolactone, and that is the eplerenone. So eplerenone is given for the male patient to prevent from the gynecomastia in the adrenal hyperplasia. So as one more point I want to discuss, that the differential diagnosis of the Conn syndrome. As we know that in Conn syndrome, there is the adrenal tumor of the first layer of the adrenal cortex, which cause the increased level of aldosterone, and aldosterone act on the epithelial sodium channel, and it causes the sodium and water reabsorption and potassium and hydrogen loss. Same is in the Liddle syndrome, but basically the difference is that in Liddle syndrome, there is the increase the function of the epithelial sodium channel. So in this, the gain of function of epithelial sodium channel, so there is the defect in the epithelial sodium channel, that it exhibit the gain of the function, and due to which that it also have the same features as the Conn syndrome patient develops. So this and in the treatment of the Liddle syndrome, we give the drug which block this epithelial sodium channel, and that is amiloride. So in this, drug of choice is amiloride. And in the Conn syndrome, the spironolactone is given initially. So initially spironolactone, and after that definitive treatment is surgery is done. So this is all about the primary hyperaldosteronism. I hope you all enjoy it.